half-life increased further with the second hormone injection. So altogether, there's an indication that lower doses of hydrocortisone can be safely administered to patients with AI undergoing major surgery, and it calls maybe for review for the current protocol in place when it comes to steroid cover. So that leads on to the suggestion to present this paper today, which was published in the BMJ in 2017, and it's essentially the DREAMS trial. So a little bit of background as to why this trial was performed. Post-op nausea and vomiting is the most common post-op complication, I think reported in over 30% of patients, which obviously in turn delays recovery and discharge. So independent predictors include laparoscopic surgery and increasing duration of surgery, which increases the risk of post-op nausea and vomiting. And actually, dexamethasone is one of several drugs recommended for moderate and high risk of post-op nausea and vomiting in the consensus guidelines from the Society for Anesthesia. And in a previous trial of over 4,000 patients, it was found to effectively reduce nausea and vomiting, but only 11% of these patients had actually undergone abdominal procedures. So as of yet, it's value in bowel surgery in particular is unproved. And there is another 2 single-center trials with only 100 patients undergoing bowel surgery actually reported no benefit. So before this trial design, they surveyed 6 major colorectal units in the West Midlands and found that actually only 0.25% of colorectal patients were receiving dexamethasone on induction, even though there could be a lot of benefit with using it. So the study aims were really twofold. Firstly, whether pre-op dexamethasone reduces post-op vomiting in patients undergoing elective GI surgery, and also, in addition, whether it's associated with other measurable benefits, such as a quicker return to oral diet and reduced length of stay. A reduction of post-op nausea and vomiting in this group of patients would improve the surgical experience, fast-track recovery, and decrease post-op complications. So the outcomes as they defined them is the primary is any vomiting within 24 hours. They defined vomiting as episodes of expulsion of gastric content, either reported by the patient or observed by the clinician. Secondary outcomes were quite a few. So number of episodes of vomiting post-operatively with an interval of 5 minutes, defining separate episodes, the use of post-op antiemetics, the severity of the post-op nausea and vomiting as measured by a patient-centered outcome using an intensity scale, fatigue, again, patient-measured outcome using a questionnaire, time to toleration of the oral diet, length of hospital stay, and health-related quality of life as well. So these outcomes, namely nausea, vomiting, and the use of antiemetics, were measured at 3 main time points: 0 to 24 hours, 25 to 72, and 73 to 120 hour post-op periods. Fatigue and health-related quality of life measures were actually reported on discharge. So essentially, the study wanted to compare the effects of a single dose of 8 milligrams of IV dex against standard care on patient recovery after small and large bowel surgery. It was a blinded, multi-center randomized control trial. The anaesthetist knew the treatment allocation, but patients and the clinical staff involved in post-op care and data collection were blind to it. As much as possible, the treating anaesthetist wasn't involved in the post-op care unless it was a medical emergency or extenuating circumstances. So they designed this pragmatic trial that incorporates the use of one standard antiemetic with or without the addition of a single dose of 8 mg of IV dex. 1,350 participants in total from 45 UK hospitals. Eligibility was quite broad in that it was any adult over 18 able to consent, undergoing elective open or laparoscopic bowel surgery for malignant or benign pathology. They had quite a few exclusion criteria, including diabetes of note, and obviously pregnancy, GI obstruction, and any adverse reaction to dex or taking any systemic steroids, excluding steroid inhalers and suppositories, etc. Also, if they'd previously been taking regular oral IV steroids, they had to have stopped these at least 3 months before being able to participate in the trial. So about 2,901 patients were assessed for eligibility, and 1,544 participants did not meet the criteria. About 47% were ineligible, a quarter of them declined. And then the remaining reasons were quite variable. So next, they were randomized, and they were randomly assigned in a 1-to-1 ratio between Dex and the standard care, and the allocation was made using a web-based central randomization service at the University of Birmingham. So the study interventions pre-op were that all patients underwent GA and received a routine antiemetic preoperatively, as determined by the anaesthetist, and then those patients allocated to Dex received 8 milligrams before the start of the surgery, so at induction. Those allocated to control received nothing in addition to standard care, and all the antiemetics were administered before knife to skin, and no further antiemetics were given during the operation. Post-operatively, antiemetics were administered at the request of the patient, which was one of the secondary outcomes, and dexamethasone was not prescribed within the first 24 hours post-op in either arm. So 1,350 were randomized, and there's a nice equal split. So between 2011 and 2014, 674 were randomly allocated to receive 8 mg of IV Dex at induction, and 676 to standard induction without dexamethasone. And then they were then followed up primary and the clinical outcomes at 0 to 24 hours, of which only a small proportion had been discharged at that point. These are the baseline characteristics of the trial participants undergoing GI surgery according to allocation, which actually shows a nice homogeneity between the two groups. They're very comparable. And this is particularly important because another study found that actually being female and smoking does put you in a higher risk category for post-op nausea and vomiting. But here, the two groups allocated dexamethasone or no dexamethasone are pretty similar in baseline characteristics. So they then again looked at clinical outcomes in the 25 to 72 hour period, and also the 73 to 120 hour period as well. And as you can see, there's an equal number discharged in both groups as well. So essentially, overall, about 29.3% of participants experienced the primary outcome of post-op vomiting within 24 hours of surgery, but a significantly fewer number did so in the dexamethasone arm. So this graph here shows the percentage of patients here, and then these 3 different categories are the 3 different time points. The bars with the lines here, the blue are the groups allocated dexamethasone, and the white is the group with no dexamethasone. The ones with the lines are looking at the secondary outcome of receiving antiemetics on demand, and the bars without the lines is looking at the primary outcome of vomiting experienced. So here you can see that significantly fewer patients experienced post-op vomiting in the dexamethasone arm than in the standard care arm, and that was the p-value statistically significant. The risk ratio for this is 0.77, which means that the number needed to treat would be 13. So 13 patients would need to be given dexamethasone pre-op to avoid 1 patient experiencing post-op vomiting in the 24-hour period. Differences between episodes of vomiting were not significant in the 25 to 72 hour period after the surgery. So that's 33% versus 37.6%, but it wasn't significant. And then finally, the difference had completely disappeared by 73 to 120 hours post-op. And then looking at the post-op antiemetics on demand requested by the patients. So in the up to the 24-hour post-op period, post-op antiemetics were used significantly less by participants allocated to the dexamethasone arm as opposed to the standard care arm. And the number needed to treat here is 8. This effect lasted to up to 72 hours, where again you can see a significant difference in the number of patients requesting antiemetics in the dexamethasone versus standard care arms. But by 73 to 120 hours post-op, the effect was no longer there. And this graph essentially shows that dexamethasone is still favored despite subgroup analysis, depending on the type of surgery, whether they were involved in an enhanced recovery pathway, even smoking status. And we know that being a smoker puts patients in a higher risk category of post-op nausea and vomiting, and also despite the pain relief. So essentially, this effect that you're seeing of dexamethasone having a beneficial outcome on the vomiting episodes is seen across all subgroups, as shown in this plot. So this here is looking at patient-reported outcomes, and essentially patient-reported outcomes for nausea and vomiting by time, 24 hours after GI surgery, showed that self-reported nausea and vomiting was significantly improved in the dexamethasone arm as opposed to the standard care arm. However, there was no observed difference at 72 hours. There was no significant effect between either group in patient-reported outcomes for nausea and vomiting, or at 120 hours. And then finally, fatigue and health-related quality of life as self-reported by the patient. Again, there was no differences in the index scores used between the dexamethasone and no dexamethasone group, and the length of stay was similar, with a median of 6 days in either group. So just to summarize the main findings. So first of all, the primary outcome, post-op vomiting. Significantly fewer participants in the dexamethasone arm experienced the primary outcome of post-op vomiting within 24 hours than in the standard care arm. And that was 33.2% in the standard care arm versus 25.5%, with a number needed to treat of 13 patients. However, the difference in episodes of vomiting were not significant in the 25 to 72 hour period after surgery, and had disappeared by 73 to 120 hours. And there was no evidence that the reduction in vomiting within 24 hours with dexamethasone could be attributed to any of the subgroups analyzed. Additional post-op antiemetic. In the first 24 hours after surgery, additional post-op antiemetics were given on demand to 39.3% of participants allocated DEX versus 51.9% of participants allocated standard care. So just over half of those who didn't receive DEX. The number needed to treat in this instance is 8. This effect could still be seen from 25 to 72 hours, where the rates of use remained less by participants allocated dexamethasone, 52.4% versus 62.9%, so slightly smaller difference. And from 73 to 120 hours, the rates of use were similar in both groups. So a single 8 milligram dose of IV DEX at induction significantly reduces the incidence of post-op nausea and vomiting. It reduces the need for rescue antiemetics. It increases the speed of return to diet after surgery. It was shown to be safe with no increase in adverse events. And it also demonstrated this late effect, the benefit from dexamethasone in terms of not requiring additional antiemetics lasts beyond 48 hours. And the mechanism of action is thought to be multifactorial, perhaps central neurological effects and anti-inflammatory benefits. So their conclusion essentially is the addition of a single IV 8 mg dose of dex significantly reduces post-op nausea and vomiting at 24 hours. It's safe to use and should be incorporated into routine clinical practice for patients without diabetes undergoing elective small and large bowel surgery. Having said that, there are quite a few limitations to pick with this paper. Obviously, the lack of blinding of the anaesthetists could influence post-op prescribing, although this is highly unlikely because, as mentioned, the treating anaesthetist was not involved in the post-op care unless exceptional circumstances. It is a paper that is very specific to GI surgery, so knowing that this cohort is particularly, has a higher incidence of malnutrition pre-surgery and may have, different rates of nausea and vomiting. There is a bias introduced by the increased use of antiemetics in the standard care arm. So anaesthetists administered antiemetics over and above that required by the protocol in 14% of participants, but most commonly those allocated to standard care, which could impact the observed difference. There's also a bias in the patient-reported outcomes in that analyses of patient-reported outcomes beyond 24 hours are restricted to those who remained in hospital, and so will reflect those with slower operative recovery. Also, it didn't pick up on if there's a dose-dependent effect of DEX. Would a smaller dose do? Because 8 milligrams is quite generous. And the optimal dose required to enhance post-op recovery has not actually been established. There's also exclusion of a very important but high-risk group. So this trial has only shown that dexamethasone is safe in patients without diabetes, which is actually quite an important cohort of patients. So further papers of note. So when it comes to dosing, there was a meta-analysis of patients undergoing thyroidectomy that found dexamethasone 8 to 10 milligrams had a significantly greater effect for reducing the incidence of post-op nausea and vomiting than a smaller dose of 1.25 to 5. Of note, it found a significantly higher level of blood glucose during the immediate post-op period, which obviously the paper that I just presented hasn't commented on because they excluded the diabetic cohort. The timing effect. So another randomized double-blinded placebo-controlled study in patients undergoing abdominal total hysterectomy found that prophylactic IV 10 mg of DEX immediately before the induction rather than at the end of anesthesia was more effective in having this beneficial outcome. And then finally, there is another double-blinded, randomized, placebo-controlled clinical trial in adolescents undergoing scoliosis corrective surgery. And it showed similar findings, that the 72-hour incidence of post-op nausea and vomiting was significantly lower in the dexamethasone group than in the control group. And actually, a single dose of dexamethasone did not increase the number of adverse events. So going back to the case from the beginning, so this patient needs some parenteral steroids when nil by mouth, and the plan was for her to take her normal pred early on the morning of her operation with a sip of water. And then two options were given, either the current imperial protocol of hydrocortisone 15 mg 6 hourly until she can get back to her oral daily prednisolone, or if the anaesthetists usually use dexamethasone as part of their standard protocol for nausea and vomiting, then why not give a single dose of IV dexamethasone 6 milligrams on induction? It will last 48 hours, and then the patient can double her dose of prednisolone and restart it on discharge. And the outcome was that actually they proceeded with the anesthetic protocol for nausea, and it went quite well. So the question open for discussion is, if perioperative dexamethasone is so beneficial for patients as an antiemetic, and since it lasts for 48 hours, why not give that on induction in endo patients instead of the hydrocortisone? And really, you'll be killing two birds with one stone. You've got the benefits of dexamethasone in post-op recovery, which is favored by anaesthetists and is starting, they are now using as normal protocol. And it also provides advantage of steroid cover in endocrine patients requiring surgery.
Thank you, Mary. It was very clear.
It was really clear.
It's very good. And thank you. So the email I got Lisa said 3 birds.
3 birds. I couldn't find a picture for 3 birds.
Third bird was, and this is his words, I think dexamethasone is a great general tonic, which I don't think is. He said general tonic, it's good for you for the endocrine problem, and it's not the vomiting. 3 birds. Anyway, so this is a really, because of our patients, we have 2 problems. One is the pituitary ones, we need to know if they can make cortisol. And if they get a dose of dex beforehand, then all our post-op cortisol measurements are a bit of a joke because they're suppressed.
Yeah. I mean, we've quite often had this challenge that somebody's done the cortisol that's undetectable, and then when we go through the op note, they've had dexamethasone outside the context of looking after Cushing's patients or anything.
Yes, it's
and that as
entirely
as a detective, it's often that. So I didn't know how generically they use it. What you're
So
saying
it's
is
about 1 in 4. So it's not everyone, and it's not. It's a fairly. The problem is I don't know who's going to get it. So it depends on who
in any operation.
Yeah,
an anesthetic preference.
Yeah. So the patient who Mary talked about, she had her operation done at a private hospital because they're farming them out to a small hospital near Selfridges, which is where it was done. The surgeon was in Chelsea. The anaesthetist was ours, and he was saying to one of your patients, "Can you give me some help?" So I asked him, and he said, "I love dexamethasone." It was his basically his email. He just uses it generally.
And their standard dose is 6.
6. Well, his is 6.
But
his is 6, but this paper says 8. So that's a really good question. What dose do we use? Do we use it at all? Is it a good idea? I mean, nobody else does this.
Since it lasted 48 hours, is that, I'm so sorry, Marianne, is that the first slide when you showed us the talked about the pharmacokinetic facts? Is that where we've got 48 hours from?
No, I'm not sure where I got the 48 hours from. I think
I've seen that. I've seen it.
I think I got that from you.
Yes.
Yes. Is it from you?
It is probably from me, but there's lots of.
I suppose I'm just wanting to say, do we really know it lasted 48 hours, pharmacokinetic wise? Because we talk a lot about glucocorticoid metabolism being quite variable in different people, don't we? So I suppose that's just my own.
We do, and I was going to just say that the surgical paper that was presented was implying it had a bit of effect from 20 to, but not as much of effect as the first bit. If I
well, it has an effect on reducing nausea, didn't it? And I presume, are there glucocorticoid receptors in the area of postrema? Is that how it works?
I don't know how it works on this, but the anaesthetists seem to like it. I don't know.
There are lots of glucocorticoid receptors in the brain, full stop, aren't there? So I suppose.
I think if you say how does the brain work, it's this is the problem. It's
well, I suppose just because that's the vomiting centre, isn't it? I guess so.
Yeah.
But
so it's 1 in 8. So we're going to give 8 patients or 13 dex to get one real benefit. It's significant, but we're going to give it to everybody.
Of vomiting.
Number needed to treat was 8. Did you say? Yeah.
So it depends on the outcome. So number needed to treat was 13 for the primary outcome to reduce the episodes of vomiting.
Completely different scenario.
Within 24 hours.
Should they just be on it perioperatively rather than complicated iron hypercortisone in patients with steroid dependent?
I am saying that, but only because it's another benefit. I wouldn't normally dream of using dexamethasone. It's very long lasting, very potent. I don't like it as a replacement choice. But if there's another non-endocrine benefit and the anaesthetist like to use it, then I might give in and say, okay.
Do oncologists find dexamethasone is part of their antiemetic side of their oncology treatment?
They do.
Yes, they use it very frequently, don't they, pre-chemo?
And I'm just thinking, I've always known that they use it, but I haven't really pinpointed exactly the reason. So
there are different protocols.
They would have a lot of experience of what they use. I don't know the data.
Alex.
Hi, I thought that was really interesting paper, an interesting discussion. I was just wondering, I mean, if we're going to say that dexamethasone is good because it's antiemetic, but so surely hydrocortisone at the supraphysiological doses we give would also have some antiemetic cover itself. So there's no necessarily, do we know that dexamethasone is a better antiemetic than high dose hydrocortisone?
It's a good question. 6 of dex will be something like 400 of hydrocortisone. That's the problem. It's an absolutely vast dose.
And the half-life, so going back to what Neve was saying, so I just had a quick look, and the half-life is documented to be between 36 to 72 hours. So you can imagine half the dose, which was probably still enough, will be in the system on that second day. But obviously it varies between participants. And the third thing was, is it, I mean, for our patients, the worry is that they don't get re-prescribed their hydrocortisone after the dex is worn off. You know, it's nice to, someone doesn't cross off hydrocortisone that easily, whereas they can forget to start it after the dex is worn off. So it might not be the safest thing in our patients who may need cover.
Yes, I mean, the real problem is who will give the dex in a reliable manner, because at the moment it's random. I mean, you discover it afterwards. You see a low cortisol because they're pituitary, and then it's less than 28, which is a bit suspicious. And then you really dig around the notes and you find one entry of dex given, and then you think, and then there's others who haven't had it. So it's
and also this is GI surgery, so they're very prone to nausea and vomiting. So it may accentuate any effect by doing it in these patients, whereas in our patients we may not have that much. We may have an even greater numbers needed to treat to get a proper effect.
Correct, but also it's happening randomly. Well, this is GI surgery's paper. I'm discovering it when you look. Adrenal patients sometimes have it, depending on who is the anaesthetist. That's the only thing that controls it. Yeah. It's two other hands. There's Harvey first, then Rubin, I think.
Yeah, so just moving on from Kareem's point, I've seen this from the bariatric side. So a lot of anaesthetists have their different policies on dexamethasone. Some give it, some don't. But my big concern is from the psychological point of view. So if someone gets 8 milligrams of dexamethasone, that's a pretty big dose in your general non-endocrine patients. Did the paper say anything about psychological problems afterwards? Some people getting psychosis on these high doses?
No, it didn't mention that, no.
So that's always a problem, and I've seen that a few times throughout the years of people inappropriately getting dexamethasone and going psychotic. And the other thing in the paper, there was no mention of BMI, and BMI is important for post-op vomiting, and we find that in our obese cohort of patients, because once they reach a certain BMI, your risk of post-op vomiting increases. So they may have found there's a difference in weight between the groups. But certainly for the endocrine patients, I think, you know, you're killing two birds with one stone. But we've always been taught, Kareem, not to give anything IV because we don't trust it. We should give it IM.
Indeed. There's a few papers that say maybe we can go to other routes, but this is I don't know what the right answer. I'm just putting it out there as a thought, having found. Well, in fact, he sent me this paper saying we love it, and then justifying it, and then moving.
I just wanted to say that the pharmacokinetic half-life of dexamethasone is actually 4 to 5 hours. It's not as long as 24 to 48 hours. People talk, or I don't know where it actually comes from, but they talk about the biological half-life being 48 hours. And the difficulty there is the cell line in which you measured the biological half-life. So I find it very difficult to apply that in real life. In terms of that 4 to 5 hour pharmacokinetic half-life, that's still long enough to guarantee you a day of adequate cover. Beyond a day, I think it starts getting dangerous to make assumptions, first of all. The other point I was going to raise is, Alex, Dr. Kominos mentioned that you might see the same effects if you gave high doses of hydrocortisone instead of dexamethasone in terms of reducing the antiemetic burden. The problem there is that actually, though we don't appreciate it, steroids do infuse different tissues at different rates and do have different sort of end organ effects. So there's no guarantee that by giving hydrocortisone, you will see that same effect, because it may well be the case that hydrocortisone, for instance, doesn't permeate the blood-brain barrier to the same degree that dexamethasone does. So I would just argue that in the absence of evidence, it's very difficult to say that.
It's also difficult to give, isn't it, 400 milligrams of hydrocortisone. I mean, I'm just going to do it. Give 100 QDS, I suppose. But in that other paper that Mariana mentioned, that if you have to give it before on induction, because at the end, when they're waking up, it didn't work. So yeah.
And the dose as well. So there was the other paper in thyroidectomy patients that found that it had to be the high dose to observe the beneficial effect.
So even 5 milligrams didn't work. I mean, that's a bit disappointing, really, because that's quite a lot. Was it 1.25? Sorry, 1.25.
Yeah, 1.25 to 5.
Okay. Yeah, and then the other question, just for everybody, is should we tell our anaesthetists to not give dexamethasone to our pituitary patients so that we can measure the cortisol? Or is that giving them an unfair nausea risk?
I think the fact is that we think about stopping metarapine and ketoconazole ahead of time, so we're not putting someone on ambulatory. So I think it's a relevant factor in our patients, along with others, and it's obviously about the risks and benefits for that particular patient. So, yeah, if our priorities trump theirs, then it's always nice to have as clean data as you can. But if the interpretation is completely going too muddy because they've been on meds right up to, then we could argue, you just have to accept that and not reassess as early as we normally do. I mean, if it's going to influence an early re-op, which is what the pressure was particularly, but that seems to be less common.
Yeah.
Less common, that then we can sort of, we tend to like to just watch anyway, even if it looks like, and I suppose this would move towards it looking like it may be in remission when it isn't, if that's what we're saying.
That's one danger, and the other is we might give people steroids unnecessarily because they fail. They have a low cortisol on day 4.
Yeah.
And then we go, oh, you need.
Definitely need to, you need to know, don't you, I suppose, as a minimum.
We should have had it, yes.
Yeah.
And we could just say that's what we need.
And in terms of finding out who's had it, when you've looked back, it's listed in medication.
I found it on the anaesthetic sheet, the one with the blood pressures on it.
It might be difficult if they've gone to ITU
How do you find-
environment.
It's slightly, in the ones I've looked at, it's saved with structure that someone's actually made the effort of
Yes,
putting it in.
because I was going to say, would you
Usually with
see-
so when Faustus draws the thyroid gland, that one's a
Yes,
picture, he's physically drawing it in.
But if you're an anaesthetist and you're prescribing IV Dex after induction, it's not, you know how
It's not
often we-
It's not on that standard drug.
Last year, I spent a couple of hours hunting through notes and calling anaesthetists because they had a patient who got a post-op cortisol of 0 that they randomly measured, and we worked out ultimately if they had Dex, but it took ages and ages.
Gosh, that's interesting. So actually, that's quite stressful because it's a bit like IT, isn't it? You can't, you've got a paper trail to work out who's had it.
I think part of the problem is we don't know who are because we need to know our patients. And they've each got their, if you talk to the surgeons, they'll tell you,
I think
if it's a difficult patient, you don't get this needs this, but that one never.
I think you're right.
Don't,
I mean, I think for us just to come in and tell an anaesthetist you can or can't do this, it needs to be explored with
That's why I want
discussion.
I want to make sure we all understand the benefits before we go into any discussion.
But I mean, again, the wider benefits of it, if it's commonly used in antiemetic and it works, then and that's the priority and length of stay is
to justify stopping it because that's so clear in data that you've got a reduction in above standard antiemetics.
Yeah.
And you think, oh, what's a bit of vomiting? But actually, if you're being sicker over and over into a sick bowl and then the day after your operation, it's not so nice, is it?
Is that the problem after the
exactly, that's abdominal surgery. So
Yes,
well, there was thyroid as well.
Well, I think it's not the GA related though, rather than.
I've discovered that some of them have had it when the cortisol was low. This is going backwards. I was looking at numbers, and then there were some who basically they passed SNAC really well or ITT 6 weeks later, and they were terribly bad. So this is like a bit of not an audit. I wasn't a full audit. I was just looking up a few random patients to work out, and then found these 2. So that's how it's come about.
It's surprising though, because normally the surgeons they tend to work with anaesthetists in pairs and have a couple
I think COVID has broken that.
Someone
like
that with COVID.
Okay. In the last few months.
Yeah, exactly. So Nigel will work with 1 or 2.
Yes, and I think it did used to be like that. So used to have the name sort of very specific, but I think because they've lost their surgical day, it's slightly all covers.
Yeah, no, I mean, the fact that this operation has been done at a small private hospital with a surgeon from one place and he's from another hospital is the kind of issue they hit. An elective hip replacement.
Slightly different.
No, she's on cred for her CAH. So she's
I think more general orthopedic type stuff. They may have. I don't know how that works, to be honest. But I think for some specific surgeries, they tend to go with the same. Like neurosurgery.
Yeah, and Fausto and Amy tend to have the same.
Yes.
Don't they?
Well, they have had two. One of them very good at Theo's. You know, one who.
Billy, isn't there? Who's on all the pregnancies.
Yeah. Yeah.
And it's very relevant for adrenal surgery and
Absolutely.
pituitary surgery that I suppose it could just be something that we have a box that's ticked, they did or didn't get it. I mean,
We should outline
Can
and mention.
Masterclass.
Yes.
I think I need to talk to a few anaesthetists and find, because what I'm discovering is it's not 1 in 4 give it. It's really, and it's very much person dependent.
Yeah,
There
it
were
might be
protocols,
that a lot of,
different
might be.
ages.
there might be other factors influencing it, like types of surgery or
Yes, there might be.
places that anaesthetists work.
Yeah.
Training.
In terms of reduction of vomiting, it was lost at 73 hours,
Yeah.
wasn't it?
Yeah.
So I suppose obviously we don't have patients vomiting unnecessarily, but if we're anticipating they're going to have an inpatient stay post-operatively that's greater than 72 hours, I just like devil's advocate. Because I think, yeah. I mean, obviously you're not going to interfere with what the anaesthetist is saying. but-
Yeah. Explain that. So if they're staying for 4 days,
Yeah, because the benefit of dexamethasone is lost after 72
Yes.
hours. So if we're saying the reason to give them dexamethasone is because it reduces their post-operative stay and obviously it helps them feel better, absolutely.
yes.
But being a bit mean, if
Okay.
they're going to be in for longer than 72 hours anyway,
It will
we
change
want
the
to keep
next
them
day.
safe. And there are alternative antibiotics that can be used. And I don't know what the reduction was in terms of numbers of vomiting, for example. Like obviously vomiting is hideous.
Yeah.
But if we're looking at reduction from 8 to 7 episodes,
Yeah.
is that particularly relevant if they're going to be in for 5 days?
I'll tell you, I'll
Okay,
tell you that
and-
there's a big drive for Nigel to reduce his length of stay.
Sure.
Right.
Okay.
And he comes in on a Saturday, he's saying to me, he comes in on a Sunday. And yes, but as long as they're on some bread is one option, right? But we don't get the cortisol and all those measurements because we've got to wait for Dex's worn off.
I mean, I think this is a more generic issue you're raising, which is we need to have a more streamlined system for early discharge, where they, for example, use PIU for daily blood tests. If that's what we worried about with one patient, and weekly blood tests for someone else, so we pick up low sodiums or borderline cortisols, or we test them once the data's cleaner or whatever.
Yeah.
And we can do that with the right thought process, probably, because we have got, for example, PIU or another pathway. I'm just thinking off the top of my head. But there isn't a neurosurgical bed that's costing Nigel lots of sort of
Time.
negative points in terms of his time.
Yeah.
I haven't got the solution, but this is one part of that problem. Is what you're saying.
It is. It
I
is.
think for that to work, and I hear you, just thinking about the discharge that didn't go well at the weekend.
I'm not
Is
aware
that
of
just,
that one.
no, it's just someone went home needing steroids and didn't get any because it was a weekend discharge from the neurosurgeons who didn't really understand the pathway, do you know what I mean? So I think it's fine to say, yes, they can go. But I guess they've got to have a shopping list of the things that they need to be activated, like come back on day X. And it's all well saying if you've got to feel confident that someone's going to book it. don't you?
We would need to absolutely set it up, like you're saying,
Yeah.
and it to be watertight. So, and in fact, that's what that's what I said daily, because I mean, unless we're very exposed.
Yes.
We're very
Yeah.
exposed.
And the other problem is
Unless
the
we have
pituitaries
another-
come from Guildford
I
and,
know.
you know, it's not easy to come
Even
back from a
sort
big
of
blood test.
Hillingdon, I think, is a bit of a.
It's
like
stressful,
transport
because you're
for a
saying you've
regular
got-
blood
We
test,
used to say
isn't it?
go to your GP, and of course that's very vulnerable now. And then so come up here for a blood test, and then when's the blood test place open? They've got to book,
Yes.
and they've got to get here. I mean, everything is fraught with. So then the safe thing is cover them with PrEP.
Yeah, which they may not need. But anyway.
So we think the safe thing is that may be
Yes.
harmful. I understand
Yeah.
what you're saying.
Yeah. Thank you, Mariana. That was really helpful.
It was really good. Thank you,
And that
Marianne.
discussion was really important. And although we haven't solved it, we at least we're all more aware now, because that's really critical that this is happening.
It looks like it's the medulla, by the way. They've done some animal studies. It looks like it's the midbrain and the nucleus of the solitary tract.
Okay.
From what I've looked at, I was just interested where it all worked. And